Am I audible?
Hello, ma'am. Good morning.
Good morning. Let me know when we have to start.
Hello. Am I audible, ma'am? Hello.
Yeah, you are. Am I audible?
So, yeah, you are. I think some issue with my this sounding system, ma'am. So today, good morning to everyone. Today, our topic of presentation is margins in the resection of head and neck cancers. So our presenter for today is Dr. Munita. Madam is Professor, Department of Pathology, Tata Memorial Hospital, Mumbai. So welcome you, madam, and go ahead.
Thank you, Poonam, and very good morning to everybody. I'll just start sharing my screen now. Okay, I hope my screen is visible.
Yes, ma'am. Your screen.
Okay, so the topic is margins in head and neck resections. So I'll basically be discussing how we assess the margins and some very basic points about which we need to keep in mind while evaluating margins, right? So the essentials of a pathology report once the surgery has been done. Once the surgery has been done and after pathology evaluation, the three key elements that we provide in a histopathology report are the margins of excision, the staging, TNM staging, and any adverse prognostic features that will tell you about the biology of the disease. So margins forms one of the most important information that is provided in a pathology report, and that is the topic today. Why margins are important is, again, they are important prognosticators. They determine the presence of positive margins is associated with decreased survival and increased local regional recurrence, and it has been documented at all head neck sites. And there is an in oral cancers, increase in local recurrence by 90%. Leads to an all-cause risk of all-cause mortality at 5 years by 90%. So out of all the other factors of the cancer, this is one factor which can be controlled by the surgeon. So that is why it is a focus of so many studies. So before we assess the margins, there are some prerequisites which are important to keep in mind, that the specimen that is sent for the proper margin evaluation, it needs to be sent intact. There should be no attempt to cut into the tumor and see the tumor because that can affect the assessment of the margins. So there should be a resistance for the urge to cut the tumor and have a look at the tumor. In case there is some damage to the while during the surgery, then every effort should be made to resuture it back, and that specimen should be physically handed over face to face for accurate communication, so that there is no wrong labeling of the margins. Otherwise, the margins can come false positive. The other most important point is that if for margin assessment, it is absolutely essential that the specimen is oriented, and all the orientation marks are provided. For larger specimens, sometimes it is possible because of the anatomic lab. But for smaller specimens, it is impossible to know what is the orientation unless it is marked. In our institute, as we know, we have usually these are marked by suture threads, the length of the suture threads, and this has to be accompanied by a check which is properly labeling what each tag implies. So this part of communication is very important. And another important information that we also need is whether this patient is, had a previous radiotherapy, neoadjuvant chemoradiotherapy, because in those cases the tumor may be there may be irregular tumor shrinkage, and this also needs to be taken into account. And of course, the margins vary with the type of specimen, so complete information of the type of surgery is also important. So sometimes there is a discrepancy between what the form says, which is pre-filled, and during the surgery there may be some additional modifications on table, and they don't go into the requisition form. And so it's important that the requisition form, which is sent to the pathology department, includes all the information about the specimen. Sometimes some 1B lymph node is included as a part of the main specimen. That should be mentioned out so as to avoid any kind of errors in pathology evaluation. So on-table evaluations, on-table modifications of surgical resections should also be mentioned. And the best method or the ideal way to examine, to get the orientation or perfect communication is physical face-to-face handover between a surgeon and a pathologist. This is not possible for each and every case, but for cases which require special, where there is some special modification or some damage during surgical removal, or there are some margins of concern, a face-to-face communication should be done. So coming to the resection margins, how we assess them. Again, emphasizing that the margin, there is no fixed way to assess margins, and there is no fixed margins that have to be taken in all the specimens. The margins will vary with the type and complexity of the specimen. Now, broadly in head and neck, the margins that we assess are of three types. These are the mucosal margins. These are basically the surfaces that you are going to cut during surgery. These are mucosal margins, where the mucosal cuts are taken. The deep margins, or the bone margins. The deep margin, this terminology, there are a lot of alternate terms which are used for deep margins, like the soft tissue margins, or the circumferential margins, or the base margins, or the base of the resection. So these all basically mean the same thing, and for the presentation I'll be using the term deep margins. And in some of the cases where lip is included, you can have mucocutaneous margins, which include the lip margins. And if the skin is involved and is a part of the resection, in cases where the tumor is fungating or involving the skin, a closer skin margin is also taken. So in this cartoon, from the top view, you can see this is the tumor, and the surgeon always tries to take out a cuff of normal tissue, and the edges where it is cut, this healthy tissue is the mucosal margin. The entire the edge is the mucosal margin, and the undersurface, wherever the deep soft tissue is cut, that circumferentially forms the deep soft tissue margin. So it is the entire cut end or the cut surface is the margin, and the entire cut mucosal edge is the margin. But it is impossible and impractical to sample the entire thing and visualize the entire thing. So for assessment, what we do is that the mucosal margins are examined just like that. But for the deep and soft tissue margins or the base, we need to ink them so that we are able to assess them under microscopy, which is the cut edge. So these are inked before the specimen is cut. There are two different ways in which we take margins in general. Either a margin can be taken as a radial margin, where the tumor, where the section is taken perpendicular to the tumor, perpendicular to the cut surface. And this allows, the advantages it allows to record the distance of the tumor from the margin microscopically, because we have the tumor, or at least it is a radial margin. So if the surface is inked peripherally, so on microscopy, it helps us to, this radial margin will help us determine the distance from the inked surface. The shave margin is, as is explanatory, it is the shave or parallel to the cut end that is taken usually for bone margins, or when the tumor is very far away. So conventionally, all the mucosal margins in head and neck are taken as radial margins. That is, they are taken perpendicular to the cut surface. And the deep margins or the soft tissue base is also taken as a radial margin. Whereas the mucocutaneous margins of the lip, they are taken as shave margins. That is, they are taken parallel to the cut ends, and the bone margins are also taken as shave margins. So I'll just give you an example on how we assess these. This is a buccal mucosa resection, wide excision. What you have here is, and I haven't made it full screen, sorry. So what we have is here, we first determine where the tumor is. The tumors can have any type of outline, and we try to basically visually identify what is the outline and where all it is going close to the cut end. So these are the cut ends, and here it has been orientated by the surgeon. By which we know this is the anterior, this is the superior, this is the inferior, and the posterior. So if it is not orientated, it is not possible to label these margins in terms of their spatial orientation. So we measure the distance wherever it is. So the entire thing is a margin, but we try to measure wherever the tumor is going closest to the margin, and we take perpendicular dimensions in millimeters. So for tongue, this is here, we can see there is a tumor, a cuff of normal tissue. Here you have the anterior margin, the medial mucosal margin, the posterior margin, and the lateral margin. So for wide excisions, this is the basic terminology that is usually used, and it is based on the orientation provided by the surgeon. And after recording the dimensions and inking the soft tissue end or the deep base, we serially slice the specimen. This sectioning is called the bread loafing, where 2 to 3 millimeter apart, the slices are cut perpendicular to the surface of the tumor. And these slices are laid down from top to bottom, and they are visualized. And this is to assess how deep the tumor is going to how close the tumor is going to the deep surface. So these are visualized, and the slices where the tumor is going closest to the deep surface are selected, and the distance is recorded in millimeters. So we sample the radial mucosal margins as well as the ones which have the with the base where it is closest. So this is what it looks like on microscopy. This is a normal looking margin where we don't find any tumor. And here this black ink is something that we recognize as the cut surface. So if the tumor is away, we record the distance and confirm it on microscopy as well. So a tumor at the margin towards the ink margin would be a positive margin. So soft tissue would look like this, something which it is with the presence of this ink on microscopy that we identify microscopically that this is a margin surface. So this is a buccal mucosa, another specimen, buccal mucosa composite resection. So the margins that we take in this are again the anterior mucosal margin, the medial margin, the posterior mucosal margin, and the lateral mucosal margin. So sometimes the terminology may differ between what the surgeon and the pathologist are using. So it is important to harmonize the terminology so that both understand what is meant by that. So the lateral here could be written as superolateral or superior margin, and medial margin here can be written as inferior-medial or inferior margin by the pathologist. So it is recommended, or it is optimal to also include in parentheses or in brackets what anatomic landmark is it. For instance, a superolateral should be in bracket, maybe mentioned as a buccal mucosa, and here it may be mentioned as an alveolar or floor of mouth for better communication. So eventually it is very, very crucial to have a perfect communication between the two sides. So this is the bony cut margin is taken as a on-shave margin. Here we have a hemimandibulectomy specimen, and the only margin which we are concerned with is the anterior bony cut end, and this is taken parallel to the cut end, is called as the shave margin. So for a right hemimandibulectomy, the margins will be the mucosal margins will be again the anterior mucosal, the medial mucosal, the posterior mucosal, and the lateral mucosal. And in addition, we also have an anterior bony cut margin. So For a left bite resection, the margins that will be taken will be again the mucosal margins and the bone margins. And regarding the deep margins, it is based on the specimen and the tumor. If the tumor on palpation has a soft tissue component, then a soft tissue or a deep margin is also taken. So it all depends on how the tumor is placed and does it have a soft tissue corresponding to it. So here you have the superior mucosal margin. It is recommended to mention the anatomic site as well, so to make it more clear. The anterior mucosal margin, the superior mucosal margin, the posterior, and the inferior mucosal margin, which reflects the mandibular margin. So these are the mucosal margins. Bony margin is the anterior mandibular cut margin, and this is okay for the mandible. For this bite dissection, it has a marginal maxillectomy. So here you have an anterior maxillary bony cut margin, the superior maxillary bony cut margin, and we'll have to find out there will be a posterior maxillary bony cut margins also. So for each specimen, you have to take the mucosal margins if it includes and a soft tissue deep margin. If the tumor is just sitting on the bone, then there will be no deep margin. If there is a skin flap here, again, there will be no deep margin. So this is about the margins in the oral cavity. So it is not possible to cover all the specimens, but another one specimen, which is a common specimen, is a laryngeal specimen. And it is important to see what are the different, how is the tumor spreading. And the margins in this would be basically, now this is one of the laryngectomy specimen. And again, here are the mucosal cut ends, which can be appreciated and first have to be identified on gross. We cut the larynx posteriorly along the cricoid cartilage and inspect the relationship of the tumor to the to glottis, supraglottis, and subglottis. And then we assess the distance of that tumor to the different mucosal margins. So the mucosal margins that are taken are posteriorly, we take the posterior margin, which is actually the arytenoid margin. Then we have the right and the left lateral margins, which are basically at the PFS or the A fold margins. And anteriorly, we take at the base of anteriorly, we have the anterior-inferior margin, which is the valvular cut or the preepiglottic cut. So in the soft tissue, we take the anterior soft tissue cut margins. The larynx is inked completely, and anterior strap muscles, they're mentioning that is important. And distally, we take the tracheal cut margins. So that is about, that is in general an overview of how we assess, measure, and sample the margins. And there are different other methods also, but this is the method which is used worldwide. Now, the other important thing is how do we report them? All the margins which are microscopically and grossly negative are regarded as negative margins. Margins which are microscopically positive are called as R1. Margins which are grossly positive are R2. Now that part is all right. Then what we call as positive margin is when you have tumor which has been cut through when the surgeon has cut through the tumor, and that is when you have invasive or carcinoma in situ at margin or within 1 millimeters. Close is regarded by convention as 1 to 5 millimeters. I'll just briefly discuss a little bit more about it. And negative margins or clear margins more than 5 millimeters. So this is something which is a standard traditional status of the margins. And but as far as what is a safe margin or what is the adequate clearance of margins, that is still very much a work in progress. What cutoffs are required? What are the cutoffs which are important and actually clinically relevant? That is still many studies are going on. Interestingly, a survey by AHNS member surgeons showed that when they were asked about what is their impression of a clear margin, 46% of the surgeons had a clear idea that more than 5 centimeters is a clear margin. While a majority of the surgeons, they said that it is either 1 centimeter, or it is one high path field, or it is an absence of inked margin. So these are not wrong answers, but it does tell you how varied the impression of a positive or a negative margin is in the surgical community. And it is not easy to, still we are struggling with, or we still don't have an absolute cutoff which is clinically significant, is because it is quite challenging to do these kind of margin adequacy studies, because these need to be anatomic site specific. You have to exclude there are confounding factors like primary recurrence versus second primary, and it is a continuous variable, the distance to the closest margin. And all these studies are mostly retrospective, and there are limitations of sampling. And also these patients, the ultimate goal with which the clinical significance or outcome is correlated is the local regional recurrence, and that is confounded by treatment as well, administration of adjuvant treatment. So it is still a work in progress. Another factor which also affects margin assessment is the tissue shrinkage, and I think we all are now aware that at the moment the specimen is removed, there is variability of tissue curling and shrinkage, and it happens to all the specimens. And this shrinkage is attributable to it's a multifactorial process. There are multiple things that contribute to shrinkage, and it can vary from case to case and from site to site. About 20 to 40% of the shrinkage is due to the muscle contraction that happens immediately after removing the specimen. And this would be more for tongue specimens compared to other floor of mouth or for alveolar specimens. Then you have resection technique also has a role. It depends upon what resection technique was used, that also contributes to a minor proportion to the shrinkage and curling of the tissue. Then formalin fixation has a variable effect. It can be from 10 to 30%. So tissue shrinkage, approximately 30%, can happen after removing the resection. So most of the studies have shown that to obtain an eventual 5 millimeter microscopic margin, we should aim for a resection with 8 to 10 millimeters clinical margin in vivo. So because this is to account for the shrinkage that would happen and eventually give you a final margin of 5 millimeters. So many different studies, many different cutoffs, and for what we know is that for oral cancers, 5 millimeters is the cutoff that we have right now. For glottis, a 2 millimeter clearance is adequate. Some studies have quoted even up to 1 millimeters. And for oropharyngeal salivary gland, 2 millimeters may be adequate. Oropharynx, especially in HPV positive cancers, lower margin positivity, closer margins may be acceptable. So how many millimeters? There are many studies which have looked at millimeter to millimeter impact of closed margins. Studies have shown that with each increase in millimeter closeness to the margin, that is as you increase the millimeters away from the tumor, increase the clearance, the risk of death reduces. If there is positive margins, if with every millimeter there is a 2.45-fold increase in risk of death, and with the closed margins less than 3 millimeters, a 1.5-fold increase in death compared to more than 3 millimeters. So different cutoffs are being offered by different studies. 28% has reported local recurrence rate of 28% for less than 1 millimeter, 17% for 1 millimeter, and And other studies have said that a 33% decrease in local recurrence risk with every increase in 1 millimeter margin width. So what is important is also that there are other factors which also play a role in local regional recurrence, and they have to be taken into account. So that is why what makes these studies very difficult to get a correct independent cutoff. What most of the studies and literature are heading at is that the cutoff of close margin lies somewhere between 2 to 3 millimeters. It is here where the rates of local recurrence increase. Even in our own study in TMH, on 602 patients, it was found that 5.5 millimeters is a cutoff for buccal carcinomas and in early stage. And if you can see that even with the stage, the cutoff may vary. So 5.5 millimeters for early cancers and 6.5 millimeters for advanced cancers was found to be an optimal surgical margin. And margins beyond 7 millimeters, they do not improve any local regional recurrence. So a very important study there. From Memorial, there is a cutoff that they found which significantly affected the local regional local recurrence-free survival was 2.2 millimeters. Now it is actually difficult to get a very accurate measurement to the tune of 2.2 millimeters, but it is doable. But it is but still it is significant to get a cutoff which is well validated. And then there are risk models which we are seeing and all these take into account, these are based on what a predefined rate of or acceptability rate of recurrence. So if your acceptable rate of local regional recurrence is 10%, then it has been found that the safe margin clearance would be 3 millimeters for a patient without BNI and 5.5 millimeters for a patient with BNI. So what all this emphasizes is that apart from margin, the other factors, histopathological factors, adverse factors play an important role in contributing to the local regional recurrence. So of its own, the close margins may not be itself do not impact local recurrence, but when taken into account with BNI and others like the worst pattern of invasion and lymphovascular invasion, they contribute to local regional recurrence. So in the setting, so by itself, it may not have any effect on recurrence or survival, but a close margin in the setting of an adverse histopathological feature like BNI, LVI, and worse pattern of invasion 5, the higher rates of recurrence and worse TFS is seen. So the other issue is of margin assessment from the surgical defect derived or the tumor bed derived sampling versus the specimen derived sampling. In TMH, we've always followed the specimen derived sampling, and it is now very well shown that tumor bed biopsies are not reflective of the true margin status, and they do not predict local control, and they are it's difficult to reliably assess the margins for the pathologists as well, and there is a high rate of inter and intra-observer variability. And in an interesting study, it was asked even after 5 minutes, the surgeon was asked to re-identify the location of the sampling, and there was a mean error of 9 millimeters for mucosal margins and 12 millimeters for deep margins. So tumor bed versus surgical derived tumor bed has low sensitivity and a lot of false negative rate. Specimen derived margins are much more reliable. And just lastly about the frozen section assessment. Frozen section assessment is basically to check the need for resection or revision, and it is its advantage is it is a rapid test. You can on the table get the report within 15 to 20 minutes, and there is a high rate of concordance between the final and the frozen section. In most of the academic centers, it is upwards of 96%. but there are challenges associated with frozen section. And one of the main important source of error in margin assessment is the sampling error. So there can be a missed sampling. So the frozen section which is sampled in the section which is sampled in the frozen may not be representative of a true margin. So up to a 20% or 22% margins which were sampled in the frozen turned out to be later some other margin was positive or close on final in up to 22%. And there can be an interpretative error by a pathologist as well. So these are the sources, and the basic outcomes of a margin revision are you can convert a positive margin into a negative one. The other possibility is that a positive margin can remain positive, and or the third is the revision may be of indeterminate quality. And the important thing or the problem or the challenge with the tumor bed revisions is that it's very important for the surgeon to send which side is away from the tumor. That communication has to be there. Otherwise, there can be an interpretative error. There can be an error in interpretation, because it has to be linked which side of the tissue which is sent as a revision is the true margin and which is the false margin. It's important to label the true margin. And it has been seen that revisions can be off target for about 1 centimeter in about a third of cases. And many cases show discrepant spatial relationship between a positive and a revised margin. For instance, the margin at soft tissue may be positive on frozen, but the revision that is sent in the next couple of minutes, that just shows a tissue which has mucosa and submucosal glands, which you can basically see is not from the deeper, it's not a tissue which is deeper to the tissue which was previously positive. So there is a high rate of false negativity with the revisions that come, and many studies have shown there is a lack of benefit of revisions. There's a meta-analysis of 8 studies which have shown that R1 to R0 conversion, its actual benefit or translation into clinical benefit is only equal to initial R0. So margins that require repeated revisions actually may carry a high risk of recurrence, more than 25%. So margins that come positive initially, they basically reflect bad biology, and they itself cause more than 25%. Nevertheless, our goal is to revise and achieve an R0. So not only in terms of utility, in terms of clinical benefit, but also cost-wise, frozen sections do not, the benefit does not add up. The cost-benefit ratio is 12:1. This is a study done, our own study. And most of the studies have shown a benefit of 0.7 to 5%. Interestingly, in the study, it showed that the microscopic spread changed the gross margin status in 5.2%, and the revisions were possible in 2.3%, and adjuvant treatment plan was changed for 0.7%. So we can clearly see that the frozen section is for margin assessment is not a very, very useful modality. Then versus the gross versus the frozen section, again, both gross examination by surgeon versus a frozen section showed similar rates of detecting inadequate margins. Again, so currently the trend is, if this is the algorithm for the main resection specimen which is assessed in frozen, it should begin, and the authors here in this very nice reviews write that begin and hopefully end with the gross examination. So the basic algorithm is you see a lesion or whether you don't see a lesion. If you don't see a lesion, you can decide not to freeze anything, or you can do a random representative section. But if you see a lesion or a tumor, you can orient it, ink it, you can cut and examine it and measure the distance and report to the surgeon. This can be done by the surgeon who's adequately trained and or a pathologist. And if on gross examination it is more negative, all the margins are negative or more than 5 millimeters, or it is not possible to revise the positive margin or the closed margin, will be revised based on the cross-examination. So that can be the end of the consultation, and all the revised margins can go to the permanent pathology. But if on the other scenario is there is a primary diagnosis the surgeon wants to know, or the depth of invasion, or wants to confirm the distance of a closed margin, then in those situations lesions can be freezed. So the role of intraoperative assessment of margins is really shrinking. Just the last slides that there are some adjuncts, some advancements which are happening. There are a whole lot of optical and imaging adjuncts that can be used to assess which are the margins which are likely to be to later on lead to recurrence. In terms of molecular margins, also a lot of research and a lot of studies ongoing. P53 is one of the marker which stands out, because P53 mutation is associated with local regional recurrence. But then there is EIF for E overexpression, which is associated. Then epigenetic microsatellite instability, loss of heterozygosity, then certain genomic high-risk signatures. These are some of this is the work which is ongoing, which is exploratory, not currently used because there are too many challenges of application in the routine. These would basically require a complete margin sampling. Cost is an issue. Results are not available immediately, but it is an exciting field. So my last slide is that margin assessment is a very crucial part of pathologic evaluation. Is an important prognosticator of local regional recurrence. Very important to orientate the specimen, correctly label it, and ensure a good handover, and to ensure that the specimen and the communication between the pathologist and surgeon is perfect. Margins can vary with the site of anatomic site and stage, and broadly the margins are mucosal, deep, and bone margins. We should aim to achieve the conventional 10 millimeters in vivo margin to achieve a final 5 millimeter pathology margin. And the role of intraoperative frozen section is shrinking and is not proving to be clinically beneficial. Thank you.
Thank you, ma'am, for such a comprehensive presentation. So I would request if anybody has any question. So ma'am, I have one question. We are doing one study on gross versus this frozen section utility in our head and neck cancers, which is going to be a randomized study with Pankaj sir and Vidisha. So I think that one point which you showed in this presentation as well, that I have this question that how feasible or how easy it is to train the surgeons the assessment of the third dimension. So as because you like you described in the presentation that the proper radial resection or radial division of the specimen is needed to assess the deep soft tissue margin. So the question here is how feasible it is. Just for my own understanding, I wanted to know.
So Poonam, your concerns are very valid, because I think the deep margin is the one which is the most difficult to visual, because it is not visualizable. It is to be palpated, and that is the one which is likely to be positive also in many cases, because mucosal margins are easy to visualize. But as far as evaluation is concerned, I don't think there is much difference in surgeons versus pathologists. What is required is a period of training. A learning curve is there. The period of training is required. After that, once the terminology and the method of assessment is familiarized with, there is no difference between a surgeon and a pathologist. In fact, the surgeon is much more better equipped, because the surgeon knows exactly what landmarks he has cut or where he has taken the cuts. So actually there is no concern as far as whether the surgeon will be able to do it or not. But Definitely a period of training or a period of just familiarizing with the method of assessment so that you don't damage the specimen, and what is the accurate way of measurement. A period of that can vary from person to person, but on an average per site, if you see 5 specimens, how they are done accurately, or using some training videos, it can be achieved. So,
okay, ma'am. Yeah. You rightly said that, because the deep margin is the most important margin for us also, because mucosa and bone cut are easily visible and they can be done. That's why that was my concern. I think, ma'am, there is one question in the chat box.
what is the importance of salivary gland involvement in reporting? Salivary gland, I think removal is primarily for, is this in regard to margins, the question? But or otherwise salivary gland margin and salivary glands are removed as a part of neck dissection. I think it facilitates. It's more of a surgical requirement than a staging requirement. But in a small proportion of cases, they can be involved, and that needs to be documented. That doesn't change the staging, but it does reflect the biology of the disease, that it is quite aggressive.
Or ma'am, this could be the primary lesion of the salivary gland. If the lesion is a primary lesion of the salivary gland, then we have to take a cuff of soft tissue around it.
Yes.
So whatever it is, we have to, like we do in parotid also, we do a adequate parotidectomy, which means that whatever surrounding tissue is around that gland, which is involved by the tumor, specifically is if it is a primary tumor of the salivary gland, then try to take a cuff of soft tissue, though there can be limitations, but still that can be, should be the aim if it is a primary.
So regarding salivary glands, again, the cutoff for salivary gland, what is the adequate clearance is still not defined, but a 2 millimeter is considered as a safe clearance for malignancy also.
Right. I think there are one or more questions. So another question is, if we take re-resection of the closest margin on table after primary resection, is there any difference in outcomes? I think you already answered that.
Yeah, so actually it is a matter of great concern that many of the studies have shown that even the re-revision does not actually translate into the benefit. So there is a marginal, the studies have shown there is a slight trend. Revising is better than not revising, but the benefit, it is not equate, it doesn't equate to an initial R0. So that also lets us believe that it is mainly because the disease, those cancers which are initially margin positive are the ones which are biologically aggressive. So they have other factors also which predispose to locoregional recurrence. So overall, margin alone is not a factor which determines the locoregional recurrence. It is an important factor, but when we take the closed margins or the revised margins, the other factors also play a role, like the PNI especially, and pattern of invasion. So it's a very multifactorial thing, but most of them have shown that while our goal is to achieve R0, and the ones which are converted from R1 to R0, they have a marginally better performance, but it usually does not equate to R0, initial R0.
Yeah.
I hope I
so
answered.
Right, ma'am. In our experience also, we have seen that usually the squamous cell carcinoma, our division of one margin, usually we achieve unless with extensive submucosal disease. But usually, like you rightly said, those with PNI, especially in adenoid cystic carcinomas, sometimes after repeated margin excisions also, the final margin comes positive. So that indirectly tells us that it is a very aggressive tumor or a tumor with extension along the
with a high risk of locoregional recurrence. So margin positivity is basically a reflector of the patients who would require adjuvant treatment.
True. Ma'am, there is another question, that is the timing of assessment of the margin is also important. They're asking in terms of when did we remove the specimen and when did we check the specimen. Does that also make any difference?
I'm not sure if I understood the question, but what it basically means is if you leave the specimen for a long time sitting on the bench, it will keep on contracting and curling up.
Yeah,
So,
I think so. That is the question. Yeah.
So it should be there should not be too much time wastage, and measurement should be done and the best or the most accurate is the one which is just removed when the specimen is removed, and the longer the time, the more it contracts and more it shrinks.
I think it is in terms. So I think probably they have asked for formalin preservation. So suppose we see it after 1 week or we see after 1 month. Will that make any difference?
No, I don't think we have the data which has looked at that, but formalin fixation can have a variable effect. It is not very predictable which tissues it is going to have more effect or less, but and the duration of time, at least I'm not aware of that. But formalin does tend to cause a lot of shrinkage. It does cause, it can cause up to a third of specimens, a third of 33% of shrinkage can be due to formalin. So
Right.
formalin does play a role in tissue shrinkage. But what we need to take into account is that all the studies which assess the margin clearance, they are all based on the final assessment. So tissue, all those pre-analytical factors are affected equally. So.
So I think, ma'am, with this we conclude today's presentation. I think there are no more questions, and it was a great presentation, and we really learned a lot. So thank you so much, ma'am.
Thank you. Thank you so much.
Yeah, ma'am. We look forward to have you again after some time in our this class. Thank you so much.
Thank you. Thank you so much. Bye. Have a good weekend.
Thanks, ma'am.